Welcome to MD Insights. I'm Miguel Regueiro, Chair for Digestive Disease and Surgery Institute, and it's my great pleasure coming to you today from Cleveland Clinic with Dr. Matthew Allemang, who's a specialist in the treatment of surgical intervention for gastroparesis. So, Dr. Allemang, thank you for joining me.
Hi, thanks for having me.
So today we want to cover a couple of areas. One is get into your area of expertise in gastroparesis and some of the advancements that you've made. But let's just start with, how did you get into your field? How did you get into surgery? And then specifically, how did you become an expert in gastroparesis? What made you kind of tick and want to do that?
Yeah, like most things in life, a lot of it comes from hard work and then a little bit of luck. I started off in a bioengineering degree where I worked for a minimally invasive firm during undergrad in their research and development department, which kind of sparked my interest in minimally invasive surgery. From there, I did general surgery. It was kind of a natural extension after medical school. And during my residency, I was able to work with Jeff Ponsky and Jeff Marks over at UH. Foundation in surgical endoscopy was just influential on me and the minimally invasive techniques that they were doing. And so from there, I looked for a fellowship and found one right up the street with Matt Crow and Rodriguez and El Hayek and again, Dr. Ponsky again, and kind of fell into the gastroparesis from there. Before I did my fellowship here, I had no idea about the surgical treatment of gastroparesis at all. You know, as someone we referred to gastroenterologists for medications, and it just really opened my eyes to a whole other world of minimally invasive surgery to help these patients.
Great. And so obviously gastroparesis is such a debilitating disorder. And, you know, I think we've all seen these patients. It can be frustrating too, because like you said, oftentimes the medication and medical therapy is somewhat limited. I think we're still really understanding this. But tell us, as far as your day in and day out, as you think of your surgeries for gastroparesis, kind of what's your schedule like? How do you interact with patients? What's your OR time like? What does that look like? Yeah,
so my foundation of treating gastroparesis from a surgical standpoint is really from the least invasive to most invasive. So I'd say about half of my practice is spent doing POPs, or also known as the GPOM procedure, which is a minimally invasive endoscopic procedure to disrupt the pyloric muscle. And we see a lot of really good results of that. For every 4 people we do it on, about 3 of those feel better at about the 3-month mark. We're obviously still trying to figure out kind of long-term side effects and the longevity and the robustness of the operation. But the group here that I learned from, we've been doing it since 2016, and I've been in practice for the last 3 years doing it a fair amount as well. About 1 in 10 patients with gastroparesis will have some element of malnutrition, and some of those folks need some type of feeding enteral access. I do some of that as well. It's really helpful for their lifestyle. I mean, there was a patient I just saw right before coming here that it changed her life. So her whole family said she's a whole nother person now that she's getting better nutrition. And that's just with a simple jejunostomy tube that's just really helpful for them. We also incorporate gastric stimulators, which have fallen out of vogue over the years, but I think are making a little bit of a comeback, and kind of we find our way in the surgical treatment of gastroparesis. You know, who's better for a stimulator, who's better for a POP, and we're still trying to work on that in detail. And then every once in a while we'll do gastrectomies and kind of big surgery to take out the rest of the stomach in a limited number of patients that are either morbidly obese, they have other comorbidities that go along with that, or they've exhausted all their other options and they're really looking for some kind of help because it's so debilitated.
Great. So for the audience out there that may not know all of the acronyms, I'm going to ask
I'm
you
sorry.
to...
I'm so sorry.
No, that's good. And actually, because you're used to just the lingo every day of saying that. But for POPs and GPOM and some of that, so first of all, what are the words? And then what does it mean from a simplistic approach? How do you approach those surgeries?
Fine. So a POP is the same as a GPOM. The POP stands for per-oral pyloromyotomy. The GPOM is a gastric per-oral endoscopic myotomy. It's basically a technique that was invented in Japan by a surgeon out in Japan for achalasia. that we've kind of taken a natural extension for the pyloric muscle, which is a sphincter at the bottom part of the stomach. And we do it with the endoscope down the patient's mouth. There's no cuts on the outside. And we do it in such a way that's extremely safe with very, very little in the way of morbidity or complications afterwards, just to kind of cut that sphincter, get the bottom part of the stomach open more often to help them empty a little bit faster and feel a little bit better from all their debilitating nausea and vomiting.
Great. So when we think about the physicians and the healthcare providers out there listening to us today, Matt, tell us what about your program? What about Cleveland Clinic? Why should they refer? What's the niche that you're providing? I know you get lots and lots of referrals from all over, but for those that may not know, kind of what's the secret sauce, if you will, of the referral to you, to your program here?
Yeah, I think the big thing here is really the multidisciplinary team we've established here at South Point Hospital. And the captain of the helm is obviously Dr. Michael Klein, who gets referrals from all over the country for these unfortunate patients. From there, I usually evaluate them along with Dr. Judith Sheeman, who's one of our behavioral health psychologists. They get to see nutrition and kind of meet everyone along the way. And we've really established a very efficient throughput and kind of workup, establishing treatment plans for folks that are very tailored to everyone, and getting them in quickly for whatever treatment regimen we've come up for.
Great. So when you think about it at the core essence, I like the way you said it, that the secret sauce is really the team. It's really the multidisciplinary approach from the dietitian to the gastroenterologist, to the surgeon, to the psychologist, to just so many more that are involved in this. As you look at the future of surgical treatment in general for gastroparesis, for the patients out there now, kind of what's the hope of the future? Where is this field headed? Where do you think things are going? You've seen a lot of change already, but in a hopeful sense, I'm already hearing great interventions that you're making on these patients today. What's tomorrow look like for these patients?
Yeah, I think trying to really beat in on who would benefit from what intervention, because I think there's a lot about gastroparesis that we don't know. And there are subsets of these patients that we're trying to figure out kind of who would benefit more from a pyloric intervention, who might benefit more from a stimulator, a gastric electrical intervention where we implant leads into the stomach wall laparoscopically to kind of shock the stomach into working, or who would just be better off if we kind of took most of their stomach out right from the get-go. And trying to tease out the details between all these patients is the really exciting part about kind of the future of my job and role here and kind of figuring everything out.
And do you think there are any specific techniques or technology, even if you look down 5 years, that you're kind of excited about that may be preliminary today? Is there anything on the horizon that you go, wow, this could really be revolutionary?
Yeah, we're looking in now to measuring pre-procedurally the electrical activity of the stomach with an EGG machine to see if we can find a way to predict those patients would do well versus not. There's something called the endo flip, which measures kind of the distensibility to put a balloon through the pyloric muscle before and after we cut the muscle to see if we're cutting it enough. That's obviously a big question in my mind. It's more of a kind of clinical gestalt. Am I cutting it enough right now versus cutting it too much and that type of thing. So it's really exciting. I mean, along with just that, we've got awarded an NIH grant here at the Cleveland Clinic to do a POP versus sham trial, just to kind of prove that it works. Some of the people out there really think that it's not a great procedure, and there's a lot of kind of placebo effect that goes along with it. This trial, we're really hoping to kind of put that to rest, that we can move forward kind of with further interventions and fine tuning.
Right. So a lot of hope for tomorrow, a lot of innovation, technology, teams, experience. So Dr. Allemang, thank you for your time. I want to ask you one final question. Maybe if you were to give a few key takeaway points for the audience on surgical interventions for gastroparesis or gastroparesis in general, what would those be?
There's still hope. We're learning a lot. The least invasive options we have are really great. And we're going to learn as we go along. It's only going to get better. And it's already gotten better so much. And even the last 10 years, it's gotten better. So
that's great. Well, so we'll end on that very positive note with Dr. Matthew Allemang for MD Insights from Cleveland Clinic, DDSI. Thank you, everybody, for your attention, and hopefully you found this edition of MD Insights to be informational. Have a good day.